All right, welcome back to Grand Rounds. We have an amazing speaker and topic to bring us in for the new academic year. Welcome. I'm Allison Bonham, the medical director of Grand Rounds. And I'm really, really excited again to welcome you back and to introduce our speaker for today, who is Dr. Jennifer Price. She's a professor in the Division of Gastroenterology and Hepatology. And her work is really at the intersection of people who have HIV. They may have viral hepatitis, they may have hepatic steatosis, and then also working on the care cascade among patients who have liver disease, people who use drugs, and people who may be experiencing homelessness. So she's one of the people behind the Deliver vans that you may see around San Francisco, bringing mobile liver care to people. So has done some really incredible work and also essentially helps write the guidelines for hepatitis C. So I'm very excited to welcome Dr. Price. Thank you.
Great. Thank you, Allison, for that kind introduction and for the invitation to speak with you all today. Sorry, I have to get back to the start. Okay, here we go. So here are my disclosures. And I wanted to start by reminding everybody that hepatitis C remains a major cause of morbidity and mortality worldwide. There's an estimated 50 million people currently living with chronic hepatitis C across the globe, and 1 million new infections annually. And together, these lead to nearly 250,000 deaths due primarily to cirrhosis or hepatocellular carcinoma. So today I'm really going to focus most of the talk on giving an update on where we are now in 2025 with hepatitis C, but I wanted to start by reviewing the history of where we've come from, because although you'll see soon, we do have a lot of challenges ahead. We also have had a lot of really incredible successes. And I think that the story of hepatitis C is a story of a true success story of bedside to bench, back to bedside research collaborations. So let's start at the beginning. The story begins in the early 1970s when clinicians observed that patients who received blood transfusions had a high risk of developing a transfusion-associated hepatitis. And this was initially thought to be due to the virus that we now know as hepatitis B, but it wasn't until hepatitis B was discovered in the 1960s and hepatitis A was discovered in the early 1970s that researchers could actually test the serum of patients who experienced transfusion-associated hepatitis. And when they did so, they learned that actually only 25% of cases were due to hepatitis B and none were due to hepatitis A. So 75% of cases of hepatitis were due to something that became known as non-A, non-B hepatitis. So this clinical observation was made in the early 1970s. And then several years later, Dr. Harvey Alter and his lab demonstrated that the agent that causes non-A, non-B hepatitis could actually be transmitted to chimpanzees. And so this suggested that there was a new viral etiology. But it took over a decade of really intensive research before basic scientists here in the Bay Area at a biotech company named Chiron, which was actually founded by UCSF's own William Rutter. They used molecular cloning techniques to identify the virus that we now know of as hepatitis C. And once hepatitis C was identified, this allowed for the development of a test for hepatitis C, the very first Hep C antibody test. Once the antibody test was developed, it was quickly confirmed that non-A, non-B transfusion-associated hepatitis was indeed due to hepatitis C. And then most remarkably, once it was used to screen the blood donor pool, it essentially eliminated post-transfusion hepatitis. So you can see here, as I told you, the incidence of post-transfusion hepatitis was actually relatively high in the mid to late 1960s and early 1970s. And you can see that there were a series of interventions over the subsequent years that decreased the risk, but it wasn't until the early 1990s when there was universal screening of the blood donor pool with Hep C antibody that the risk of post-transfusion hepatitis was essentially eliminated in the United States. So this was a huge public health win. Now, meanwhile, while the basic scientists were working very hard to identify the virus, the clinical researchers were conducting observational studies to better define and characterize the epidemiologic and clinical features of non-A, non-B hepatitis. And what they realized was that transmission was not just limited to blood transfusions. They identified additional high-risk groups, including people who received IV immunoglobulin, people who were on dialysis, people who used injection drugs, and healthcare workers who had occupational exposures. They also observed that acute infection was typically mild, although it could cause a severe hepatitis. But importantly, they learned that the majority of people with acute infection developed a chronic hepatitis, and that this chronic hepatitis could lead to end-stage liver disease and liver cancer. Now, the search for a treatment also began before the virus was even identified, and the first treatment that was used for hepatitis C was interferon monotherapy. And this was in 1986, the first study that was published using interferon in people with transfusion-associated hepatitis. At the time, Hep C hadn't been identified, so they couldn't actually monitor viral loads, but they used ALT as a surrogate. And what you can see here, these are two patients with transfusion-associated non-A, non-B hepatitis. When they got interferon, the ALT improved and actually normalized. Then when the interferon stopped, ALT went back up, and then the ALT normalized again when interferon was started again. So interferon monotherapy actually was the first FDA-approved medication for the treatment of hepatitis C in 1991. But unfortunately, as I just showed you, the response to interferon was not durable. And in hepatitis C, when we're looking at cure, we are referring to something called a sustained virologic response. So that means that the virologic response is sustained for several months after the end of treatment. And you'll hear me talk later about SVR12. That means that the Hep C viral load is undetectable in the blood 12 weeks after the end of treatment. So you can see here the SVR or cure rates were actually quite low with interferon monotherapy. But over the course of several years and decades, we got to the point where in 2011, our standard of care for treating hepatitis C was the pegylated version of interferon in combination with the antiviral ribavirin for 12 months. And this could lead to cure in about 50% of people who were treated. But really importantly, there were subpopulations who had a much lower treatment response. So for example, certain genotypes, patients with cirrhosis, patients also living with HIV and hepatitis C co-infection. And anybody in this room that's old enough to remember when we use peg interferon and ribavirin to treat hepatitis C, will also remember that it came with a lot of toxicities and a lot of side effects. So much so that most people who were diagnosed with hepatitis C in the interferon era, given the toxicities and the low efficacy, were actually not treated. So now, as those treatments were advancing, the virology also advanced step by step. And in 1993, the Hep C polyprotein was characterized. And then in 1999, we had the first working in vitro Hep C replicon model. And this was really important because it allowed scientists to study viral replication in vitro. And then in 2005, we had a fully infectious in vitro system, which was a big breakthrough because that enabled high throughput drug screening for drug discovery and drug development. And the targets of the drug discovery were these non-structural Hep C proteins, the NS3-4A protease, the NS5A, and the NS5B polymerase. And so the drugs targeting these proteins are known as the direct acting antivirals, or DAAs. So the search for the cure really ramped up in earnest in the 2000s. And many of these DAAs were very effective at suppressing the virus initially, but unfortunately resistance developed relatively quickly if they were used alone. So the first DAAs that came to the FDA approval were in 2011. That's when I was a transplant fellow. And they were telaprevir and boceprevir, which are the first generation NS3-4A protease inhibitors. And because of what I just showed you, they were very potent in initially suppressing the virus, but then resistance rapidly developed if they were used alone. They were approved in combination with peg interferon and ribavirin. And you can see here that the SVR rates increased from around 50% to closer to 70 or 75%. So this was a very big deal at the time. But unfortunately, the addition of the the PI added additional toxicity on top of the PEG and ribavirin alone. So it was even more difficult for patients to get through treatment, and it was a pretty cumbersome regimen. So the real game changer occurred at the end of 2013, which is when the FDA approved sofosbuvir, which is an NS5B polymerase inhibitor, also known as Sovaldi. And this was really important because sofosbuvir could be used with ribavirin without interferon to achieve cure in the majority of patients with certain genotypes. So this really heralded what we call the interferon-free DAA era, or the all-oral DAA era that we're in now. And two main features of this DAA era is one, much fewer side effects. So much easier to tolerate, and very rarely do we see a treatment-limiting side effect. And then secondly, you can see here very, very high potency. So now we're achieving SVR rates of 95% plus. So after this initial approval, this was right before January of 2014, you can see there's a flurry of clinical trial activity after this. Many more regimens were approved. A lot of these on the slide we don't actually use anymore. And I'll get to in a few slides where we are today with pan-genotypic regimens. But as you can imagine, this was a very rapidly moving, exciting time. I had just joined the faculty at UCSF, and I can't really overstate how exciting this was for our field, because we knew how impactful cure is for our patients. So many studies have shown this. This is just one study that shows that curing hepatitis C significantly reduces the risk of somebody developing end-stage liver disease, liver cancer, need for liver transplant, and not only reduces the risk of these liver-related complications, but also significantly reduces all-cause mortality. So really huge impact to be able to cure our patients with hepatitis C. On an individual patient level, I just wanted to share some labs from one of my patients who underwent a liver transplant in late 2012 for hep C-related cirrhosis. And she developed something a few months post-transplant called fibrosing cholestatic hepatitis, which is a very rapidly progressive, very severe form of recurrent hepatitis C after liver transplant that used to be uniformly fatal. And this was before sofosbuvir was FDA approved, but we were able to get compassionate access sofosbuvir for her. And you can see here, she had a dramatic virologic response. Her viral load dropped 5 log in 2 weeks. Her bilirubin dropped from the high teens to less than 4 in just over a month, and her transaminitis resolved, and she survived, which was incredible because fibrosing cholestatic hepatitis at the time was a really dreaded complication of recurrent hepatitis C after liver transplant, and now it's vanished. And I haven't talked about it in over 10 years. None of our fellows have ever seen a case, nor will they. So it might not be surprising that in recognition of their work, the Nobel Prize Committee in 2020 awarded the Nobel Prize in Medicine to 3 of the scientists who were responsible for identifying and characterizing hepatitis C. And as they said, their pioneering work paved the way for developing the screening tests that have dramatically reduced the risk of acquiring hepatitis through blood transfusions, and has led to the development of these highly effective meds that have improved the lives of millions of people. So where are we today in 2025? Now we have fixed dose oral DAAs that are pan-genotypic, so we don't have to adjust the regimen based on genotype. We don't even have to check genotype anymore. They're short courses, I'll show you, generally 2 to 3 months. And we can get SVRs of over 95% across a variety of populations who are able to complete their medicines, and including those subpopulations that previously had difficult to treat hepatitis C. So they've really eliminated the disparities in hep C treatment efficacy in a lot of these populations that we saw before. Nothing's 100%, so we do have people that take their medications and experience virologic relapse, but we have really excellent salvage DAA therapies in those cases, and we're even able to cure people who have failed multiple rounds of DAAs. We also have much simpler treatment. So it used to be very cumbersome, both for patients as well as providers, to get somebody from diagnosis to treatment. There were lots of different steps, like I said, checking a genotype, fibrosis staging, and each of those steps was just another hoop somebody had to jump through, and we lost people along the way. But now with these pan-genotypic regimens, where it's really the same regimen, same duration, regardless of genotype, regardless of compensated cirrhosis, we can really simplify the pre-treatment workup. And we've also learned that on-treatment monitoring needs to be very, very minimal, if at all. And so in 2020, the AASLD IDSA hepatitis C guidance panel produced these what we call simplified treatment algorithms. And we call them the one pager. Everything is on one page: the pre-treatment workup, the on-treatment assessments, and the post-treatment follow-up. And this would allow people to just print this out and post it in their workstation and hopefully make treatment more manageable. We have also now in 2025 seen increased Hep C treatment in non-specialty clinics, which is huge, because having to refer somebody to a specialty clinic and then have to have them wait to get the authorization and then the appointment is obviously a big barrier. So it's much preferable, in my opinion, for people to be able to be treated in their primary care home. And then finally, we have far fewer payer restrictions than we did 10 years ago. And this, does vary by state. It's not perfect, but it's far, far better than it was a decade ago. And if anybody's interested, I just recommend this website that I included here, the HepVU, which if you pull that up, there you can see a map of the United States, and you can adjust the filters so that you could see what states still have abstinence requirements, for example, before you can prescribe DAAs, and what states still require a specialty consultation. Here are the currently recommended, the preferred and alternate regimens for treating hepatitis C in 2025. I bolded the two first-line regimens, which are what we recommend for simplified treatment. So these are people who have not been treated before and who don't have decompensated cirrhosis. And those are glecaprevir pibrentasvir, which is also known as Mavyret. That's a NS348 protease inhibitor with an NS5A inhibitor, and the typical duration is 8 weeks. And then sofosbuvir velpatasvir, also known as Epclusa, which is that NS5B polymerase inhibitor I mentioned before, as well as an NS5A inhibitor, and typical duration is 12 weeks. And both of these are pan-genotypic. So I often get asked how to choose between one or the other, and the honest answer is they're both excellent options. Both very, very well tolerated, very, very high cure rates. So you're not going to go wrong as long as there isn't a contraindication to one or the other. There are some scenarios where you may choose one over the other. For example, the GLP has the protease inhibitor, which gets metabolized by the liver. So that's contraindicated in somebody with decompensated cirrhosis. There's certain patients that have cirrhosis and genotype 3 and a relatively rare resistance-associated substitution that confers a little bit lower SVR with sofosbuvir velpatasvir, so that might be a reason that you would choose a different agent. GLP is taken 3 pills a day at the same time with food. Sofel is 1 pill a day and doesn't have a food requirement. So in your patients that might have some issues swallowing pills or food insecurity, that might be a factor. And then GLP is only 8 weeks. Sofel is 12 weeks. So some patients say, I want to be started and done as soon as possible. So in that case, you might want to choose the shorter treatment duration. And then both medications have specific drug-drug interactions to consider. But I would say it's extremely rare that we would have a scenario where we couldn't use one or the other of these two regimens. So now that hepatitis C is really curable in our patients who make it to our clinic that we can start treatment on, the emphasis in hepatitis C has really been focused on elimination. And the WHO in 2016 set ambitious viral hepatitis elimination targets, wanting to eliminate viral hepatitis as a major public health threat by 2030. And they set a couple of very specific goals, the first being to reduce new infections by 90%, and the second being to reduce Hep C related deaths by 65%. And then they called on all countries to develop their own national action plans. And the US followed suit and developed a US-based elimination goal and targets that really mirrored the WHO targets. And each year we get a report card. So this is our most recent progress report. This is based on the 2023 data. And I'll start with the good news, which is these last 3 rows here. These are our progress towards reducing Hep C related deaths. And you can see that we're getting some greens here. So we're really moving in the right direction. And I think that speaks to the fact that we are treating a lot of people. There are estimates that we've treated over 1 million people with hepatitis C in the US. I showed you the data that shows that if you treat people, you significantly decrease their risk of liver-related and complications, as well as all-cause mortality. The bad news is the first 2 rows here, and this is our progress towards reducing new infections. And you can see here, not only are we not meeting our goals at reducing new infections in the way that we'd like, but you're seeing this correctly, these trend lines are going up. So we're going in the wrong direction. Infections are actually increasing. And we've been observing that for several years now, a rise in new Hep C infections in the United States, maybe plateauing more recently. And this really parallels the opioid use epidemic. We see it in men, we see it in women, but it's really disproportionately younger people. So it's especially in people who are aged 20 to 40. More bad news, the Hep C prevalence in the US also has not changed. So there was a modeling study published a few years back now where they estimated the prevalence of hepatitis C in the US from 2013 to 2016, and they estimated around 2.4 million people were living with hepatitis C. That study recently got updated using the same methodology, but newer estimates. And for 2017 to 2020, with the same methodology, an estimated 2.4 million people in the US are living with Hep C. Moreover, when they accounted for increased injection drug use, and the modelers also accounted for the undersampling of people who use drugs in the prior models, they estimated it could be as high as 4 million people living with Hep C. So part of this is, of course, the new infections that I just showed you. But also, I think it really speaks to the fact that even though we've treated a lot of people, we're still woefully undertreating hepatitis C in the US. And it's an important reminder, I think, that having a cure available and actually getting people cured is not the same thing. And in the United States, a lot of people are living with Hep C and aren't aware of their status, but even those who have been diagnosed, only 1 in 3 have been cured overall. And that decreases when you look at people who don't have health insurance and younger individuals. So there's been a lot of talk and emphasis on how we can reach people who are living with hepatitis C. And I think in order to do so, we have to understand who we're trying to reach and how we can reach them. This is from that same modeling study. And I know there's a lot going on here, but I just wanted to highlight 3 of the highest prevalence groups. And here's the Hep C RNA positivity prevalence estimates for these groups. So 11% for people who are unhoused or unsheltered, 10% for people who are incarcerated, and as high as 44% for people who have used injection drugs in the past year. So when we think about how to meet these target how to get people treated in this target population, I think it's pretty clear we can't expect people to come to us or come to me in my hepatology clinic in Parnassus to get treated, but rather we should bring hepatitis C testing and treatment to meet people where they are. And so I'm going to show you some examples of that. And to do so, I'm going to zoom in now specifically on San Francisco. So in San Francisco, it's a little bit outdated, but our most updated prevalence estimates are that about 11,500 people are living with active untreated hepatitis C, and 90% are people who inject drugs. And when we look at the surveillance report, so this is not prevalence, this is surveillance. This is from the Department of Public Health's most recent viral hepatitis surveillance report. We're showing the reported cases of hepatitis C in 2023 specifically. And if you look on the right here, you can see that the age groups with the highest proportion of newly reported cases are ages 25 to 44. So really mirroring the national trends. And then finally, if you look specifically by neighborhood, the neighborhoods with the highest case rates of newly reported Hep C cases are in the Tenderloin and South of Market neighborhood. So in 2016, San Francisco actually became the first US city to launch a hepatitis C elimination initiative, and we call this End Hep CSF. It is a community-owned collective impact initiative, and it's comprised of very diverse stakeholders and partners, but all with a shared mission and values. We all believe that people living with hepatitis C deserve access to a cure. We draw on the wisdom of those who are most impacted by hepatitis C and engage populations that have been characterized before as difficult to engage and therefore address health disparities. And these are the 5 pillars of a collective impact model. And this is how the NTEP CSF is structured. There's 4 different working groups here in orange, including a prevention, testing, and linkage working group, a treatment access working group that I co-lead with Annie Lukemeyer. We also have an executive advisory committee and community advocates, and then a core coordinating committee. And since its inception, NTEP CSF has worked to identify gaps and barriers to the Hep C care cascade in San Francisco and come up with solutions. So for example, we know that most people living with hepatitis C are unaware of their status. So we've really worked to increase community-based Hep C screening. ZSFG, for example, has a relatively high prevalence of hepatitis C among their inpatient population. And so they have now initiated routine opt-out testing for hepatitis C for inpatients. The group has also worked to really develop a robust community peer navigation program to help linking people from their positive diagnosis to a Hep C treatment. And this group, and as well as many other advocates, were very successful at advocating for removing a lot of the DAA payer restrictions. So as of a couple years ago now, we haven't had to check a genotype before getting meds approved, which sounds like it's not that big of a deal, but actually having to draw a separate lab to get a genotype, sometimes it takes up to 2 weeks for that to come back. You have to do all that before prescribing the meds was a significant barrier. And we also now don't have a prior authorization requirement for the simplified treatment regimens, which is also really huge, because as you may imagine, the prior authorization process was pretty onerous before. In San Francisco, we've also really thought deeply about who our priority populations are and how we can kind of come up with some innovative methods to meet them where they are. And we're still, of course, treating hepatitis C in the traditional medical settings, the traditional brick and mortar clinics, but we're really focused on expanding treatment outside of the traditional medical settings into more community-based settings, and really importantly, into the more integrated care settings. So people with hepatitis C can have their Hep C treated or at a place where they're also getting other resources or someplace where they live. And there's increasing evidence that these integrative models are very effective. So one example of this was the recent rapid hepatitis C study, which was led by Dr. Shon Folade-Nweliya from Johns Hopkins. And this was a multi-center study that was conducted at 5 different opioid treatment programs throughout the United States and Canada. And we participated in San Francisco. And participants who screened positive for hepatitis C were randomized to either receive on-site Hep C treatment at the opioid treatment program with peer support or off-site referral, which didn't actually have to be a specialist referral. It was just a standard of care off-site referral. And you could see those who were randomized to receive on-site treatment were much more likely to be treated, 89% versus 21% who were randomized to off-site referral. You can see how big that odds ratio is. So probably not surprising, those who were randomized to the on-site treatment were more likely to be cured overall. But when you look at the people who actually started treatment, it was similar SVR rates, regardless of if they were treated in a specialty clinic versus at the opioid treatment program. And I'll just pause to note, I think these rates, the 68%, 67% is lower than what I just showed you before of the 95+%. This is sort of what we have been seeing in more marginalized populations, particularly people who are unhoused or using drugs. And there's a variety of reasons for this. One is that we do lose people to follow-up before we can actually confirm their cure, or we might have difficulties with venous access with the confirmatory test. And also, there are challenges to completing treatment. So in San Francisco, we've actually observed that there's a lot of challenges with medication storage safely. So a lot of loss and theft for a variety of reasons. And so some groups have offered lockers. We've also helped with sort of safe medical storage devices to try to help people be able to hold on to their medications during street sweeps or what have you. So this is a very successful model, and some of the methadone clinics or OTPs in San Francisco have really successfully adopted this. At Ward 93, the OTOP program has treated hundreds of patients, but it is intensive and it's resource intensive, and so a lot of clinics really lack the support and resources to really implement this. Now, our hepatitis C clinic has also evolved with the times, and as you heard, we now have a mobile hepatitis C van called the Deliver Care Van. And this was actually initially launched with the goal to conduct community-based hep C screening and fibrosis staging using the portable mini FibroScan device, and then linkage to treatment in patients' primary care homes. But what became clear very quickly after we started was that people really wanted to get all of their treatment at one stop. And so we were losing people at that linkage phase. And so we adapted, and now we can offer both screening and treatment on the van. And so I'm just going to walk through what we do. But we have a few different shifts, and we show up at the same day per week at the same time, so people know that we're going to be there and there's consistency. This has evolved a little bit, I'll talk about later, but our traditional model is we'll do a point of care antibody test for initial screening. That is a finger stick, and it comes back within 20 minutes. And if that's reactive, we have phenomenal phlebotomists on the van who can perform venipuncture, and then we send the blood for RNA confirmatory testing. We have to wait for that to come back. So people come back the following week for their RNA results disclosure. If that's positive, then we'll talk to them about where they might want to get treated. And if they decide they want to get treated with us on the van, they sign all of the clinic forms, the tacos, all the stuff that we sign before we see a doctor. And then our staff works really hard behind the scenes to get the authorizations in place so that they can see one of the hep C clinicians the following week. And then we do that visit through an assisted telehealth visit. So we have a hotspot on the van, and so the staff can help get the Zoom up and help assist with that clinician visit. We've already reviewed the chart, so we know if somebody does need pretreatment labs, or if they've already had labs relatively recently, we don't have to draw them. But if we do need pretreatment labs, we'll do that on the van and then bring the blood back to the UCSF clinical lab for processing. And then we send the prescriptions to the UCSF specialty pharmacy, and the patients sign a permission slip allowing us to pick up the meds for them, and we bring them back the following week, have another clinician visit to review the treatment plan and to start treatment. So we always ask people after they've been treated, how do you feel about completing treatment? And I just put some of the illustrative quotes here. So I don't think I would have sought it out. To be cured is huge. It was convenient. I usually have to wait an hour, 45 minutes, but I'm seen sooner on the van. And I was touched that UCSF has come to me because I would not have been able to go to them. So it's very convenient to have sort of this one-stop shop, I think, for all of the hep C care cascade from screening to treatment. But I think one of the other advantages is that we're trying to kind of truncate this traditional, often circuitous path from hep C testing to treatment. So this is sort of the typical traditional path that someone gets screened, and then they get their results disclosure sometime in the future or never. And then they get their pre-treatment labs drawn at some point. And then they have the visit with the clinician, and maybe they have their prescription sent then, or maybe it's the next visit or a visit after that. And then they get started. And so you can imagine that each step along this path, we lose people along the way. And that's one of the reasons why so few people in this country have been treated. So, we're able to truncate that and make it a little straighter, but we still lose people at each step along the way here. And so that made us think, well, what if we could streamline this even further? What if we can get people started immediately, right when they know their diagnosis? And that led to the No One Waits study, which was an investigator-initiated study that we conducted right during the pandemic. It was conducted at a community site. So this is the Quaker Meeting House, which is located in the civic center of area of San Francisco. So where our target population was, but importantly, not a clinical site. And first step was to do the screening, very similar to what I described on the van, except we also did point of care HIV testing. And then when the hep C RNA was drawn, we also drew a hep B surface antigen to know their hep B status. And then the following week, when they came back for results disclosure, if their RNA was positive and they met criteria for simplified treatment, they were offered same-day treatment with a 2-week starter pack of sofosbuvir velpatasvir. And we drew the pre-treatment labs that day, we had the clinician visit that day, but got them started that day, and then got insurance authorized sofosbuvir velpatasvir for the remainder of the 12-week treatment course. If for some reason we weren't able to get their insurance meds after 2 weeks, we didn't let them just stop treatment. We gave them, free meds in 2-week increments. So 89 people were eligible and 87 enrolled, which I think really speaks to the acceptability of the model. And you can see here that 71% were male, 61% reported having slept outside or in a vehicle in the past year, and 80% reported any injection drug use in the past 3 months. And really speaking to our safety net system here, 94% were insured at the time of enrollment. Among those 87 who started treatment, 79% completed treatment. And so when we looked at our overall intention to treat in the whole cohort, SGR-12, it was 67%. And among those who completed treatment, it was 84%. There weren't any adverse events that made people stop their treatment early. And I think really importantly, we didn't have to make any alterations into the treatment plan based on those pre-treatment labs that we drew the same day that they started treatment, but we didn't get the labs back until after they had already started the soft-vel. And the median time from screening to treatment initiation was 7 days. So this wasn't a true test and treat model because we didn't have RNA tests point of care RNA test at the time where we knew for sure if somebody was living with hepatitis C. But since then, the FDA just last year approved the first point of care Hep C RNA test. And this is conducted on the Cepheid Gene Expert Express platform. It's FDA approved for use in CLIA wave settings, so sort of non-traditional settings, places like our VAN, opioid treatment programs. And it's also a finger stick. It does require a bit more blood than the antibody test. That blood goes into this microtainer, and then there's a special pipette where you could load the capillary blood into this cartridge and then load the cartridge into this express system. So this system you can see here can run, there's 4 cartridges you can run at a time. There's another system that runs 2 cartridges at a time. And it takes up to 60 minutes for the test. So something to keep in mind when we're thinking about sort of high volume screening, you can only run 4 at a time and it takes an hour to run. And the results are given as qualitative results, so positive or negative. So now that we have this point of care test, the question is same-day test and treat feasible now? And I think that it is. And so our AASLD IDSA hepatitis C guidance panel just recently this year published on our website sort of an algorithm or a guide for programs that want to implement the point of care RNA and get people started on Hep C treatment rapidly. So we call this our test and treat algorithm. I'm not going to go through all the details of this in the interest of time, but it starts with the point of care testing. And then if someone's RNA is positive, you want to assess if they're eligible for same-day treatment. And then we offer guidance for what to do about the pre-treatment labs, and importantly about the hepatitis B status and knowing the hepatitis B status, because there is a risk of hepatitis B reactivation in somebody with untreated hepatitis B who's started on DAAs. Now on our VAN, we were also very excited to get funding to conduct a demonstration pilot of the point of care RNA testing. You can imagine with the workflow that I showed you that it would be really appealing to be able to do the point of care RNA at that first step rather than having to have somebody come back the following week for their RNA disclosure. So over the past several months, we've been working very hard at implementing the device on the VAN, and particularly have focused on the regulatory components. We've been working with the San Francisco Department of Public Health to develop staff training for non-medical personnel. And so this includes training in terms of performing the test, but also results disclosure and counseling. Also working on the regulatory reporting issues to ensure that we can get the results reported back to the Department of Public Health within 24 hours. And then we've also been working on our workflow. So we do screen a lot of people at every shift. And like I said, the machine can only handle 4 tests at once. So right now we're doing sort of a triage approach where some people are triaged to the traditional 2-step process, antibody followed by RNA, and others are a triage to RNA first. So we just and then there's a ongoing programmatic evaluation that we will continue to do every year to help inform us as we improve the implementation, but also to help inform other programs in San Francisco as they start thinking about how to use the point of care testing and get people started on treatment rapidly. So we just started testing with the point of care RNA test on the van in July. Overall, we screened 168 people and 81 went to the point of care RNA test, and among them 21 tested positive, so about 28%. So in the last few minutes now, I'm going to talk about some updates on what's going on in terms of Hep C elimination, more on the national stage. So some of you may be aware that in 2023, Francis Collins, who was then the scientific advisor to President Biden, announced a national hepatitis C elimination program in the United States. And this was very exciting for many of us in the hepatitis C field. The program really outlined 3 main priorities. The first was to accelerate the availability of the point of care diagnostic tests. And that's how that Hep C RNA point of care diagnostic test did get accelerated. They sort of harnessed the RADx platform at the NIH that was built for COVID diagnostic testing and used it for the Hep C RNA. And there's now a process underway to develop and test a point of care hepatitis B test. The second main pillar is to provide broad access to DAAs. And there's some really innovative models that some states like Louisiana have used, something called the Netflix model, where the state negotiated with the drug companies one price, and then they could prescribe as much as they could in a certain amount of time, having already paid. And then the third pillar is to really build the public health infrastructure to support this decentralized testing and treatment that we're going to need to achieve elimination. So this was announced in March of 2023. It still has not been funded yet. So, the point of care testing was accelerated, but there hasn't been funding for the elimination program. Just this summer, Senators Cassidy and Van Hollen introduced bipartisan legislation called the Cure Hepatitis C Act of 2025. And this would provide nearly $10 billion through 2031 to support rapid screening, treatment access, and wraparound services. And the Congressional Budget Office estimates that this will save about $6.5 billion over the next 10 years, but much, much more over the longer term. So we'll see what happens with that bill. But even more recently, just at the end of July, HHS announced that they would spend $100 million in pilot funding through SAMHSA to support hepatitis C rapid testing and treatment models in integrated care settings for people with substance use disorder or severe mental illness. So this was also very exciting, and hopefully with this funding, we will see across the country many programs starting and piloting in sort of different regions and different models. So at the beginning of the talk, I talked about the successful bench to bedside collaborations. And I want to remind people that we still need these bench to bedside collaborations. We're not done yet, and we don't have all the tools that we need yet to achieve elimination. And there's 2 additional tools that I wanted to highlight very briefly. The first is with regards to therapeutics. Hopefully I convinced you that we have excellent drugs now to cure hepatitis C, but I think what we really need is different formulation of these drugs, because it still is very challenging for some patients to be able to get all of their medicines, get the refills, take all their medicines. We don't always know if someone's taken all their medicines. They might not remember if they've taken it. And so if we had a long-acting injectable formulation of the DAAs, you could imagine how appealing that would be. We have this now for HIV, we have it for other conditions, and so it is potentially feasible for hepatitis C, and studies have shown that patients would like this and it would be acceptable. So right now, the research into the long-acting formulations is still in the preclinical phases, but hopefully we will hear more soon. And then finally, I think it's clear that if we really want to achieve elimination, we need a preventative vaccine. So I showed you the slide showing the new acute infections. once somebody has had hepatitis C and cleared it either spontaneously or through treatment, they can get a new infection. The antibody that we see with natural infection does not cause sort of a broadly neutralizing immunity. And it's hard to imagine that we would be able to achieve elimination just through treatment alone. So there's been a increasing effort now into vaccine development, and actually a lot of very interesting and thoughtful discussion about how this development could be even fast-tracked using something called the controlled human infection models, or CHIM models, which has been used in other infectious diseases and is potentially feasible and ethical with hepatitis C now that we have curative treatment. So to summarize, hepatitis C is a significant cause of death globally, and cure is life-saving. Treatment now is much simpler than it was 10 years ago. And if we want to reach people living with hepatitis C, we really need to think beyond a one-size-fits-all approach. I think the community-based, integrated, multidisciplinary care models are appealing for many reasons, but they are labor-intensive, and so resources are really, really needed in order to support those models. And then finally, like I said, we do need more innovative tools. So thank you all for your attention. I want to thank all of my collaborators at UCSF and elsewhere, all of the funders here on the slide, the tremendous Deliver Care team, and we have to update this picture. We have new members now, Sophie and Cece and Shri, some of whom are here. We have fantastic volunteers. I want to thank the NTEP CSF community, our NOW and Rapid Hep C study participants, and finally my division and my colleagues for all their support of this work. Thank you.
Wonderful. That was super interesting, and thanks for sharing that with us. Such a great illustration of a lot of implementation science work and bench side work as well. I'll start with a couple of questions of my own, and then we'll open it up to the audience here, and then see what else there might be online. But I guess to start with the end first, you ended by talking about Hep C vaccines, and just to plug, Charles Rice is actually going to be giving grand rounds later this year, which is very exciting. But in a 2-line summary, like what are the barriers to the Hep C vaccine?
So I guess the biggest barrier has been, the virus mutates very rapidly. So there's a lot of genetic diversity. And my understanding is one of the big barriers is finding a vaccine target that's going to induce, broadly neutralizing response to most people with hepatitis C.
Got it. Thank you. Also, I loved how you were talking about really like streamlining that windy road to treatment. And in terms of like how looking for cirrhosis in that algorithm changes management, if you can't assess for cirrhosis, would that change what you do in any way other than just giving Mavyret because you can't use the other one in cirrhosis, or does it change how you think about it otherwise?
Yeah, it's a great question. So I'm a hepatologist, and I do think knowing the fibrosis stage before treatment is very important because it impacts your post-treatment follow-up plan. Initially, so the SOFL and the GLP-1 can both be used in compensated cirrhosis. So in the initial assessment, I think you can rule out compensated cirrhosis sort of clinically by asking questions about compensated cirrhosis, even if you don't have labs. If you ever had ascites or a GI bleed, you could see if they're jaundiced. So then it's really, how can we assess if they have cirrhosis or not, so that we would know, be able to counsel them about their risks in terms of developing liver-related complications after treatment, and also their need for HCC screening. And hopefully you're able to get some simple blood tests to do non-invasive assessment. So I really like the FIB-4 test. All you need for that is an AST, ALT, platelet count, and age. And you really just need that, sometime in the past 6 months, or, maybe a year. So if you have that, you can just go online and calculate the FIB-4. If it's over 3.25, then you're going to want to surveil for HCC post SVR. And if it's less, unless there's other signs that someone might have cirrhosis, you can just go ahead and treat. We have the FibroScan on the van, which I'm very spoiled about, but not a lot of places don't have that. But if you do have a FibroScan, you could also do that without having to draw blood.
Great, that's helpful. So affects management moving forward, including hepatocellular carcinoma screening, or HCC.
Exactly.
Great. And then where are we on like inpatient treatment of hepatitis C? That comes up a lot on the wards here and at the general.
Yeah, that's a good question. So there have been some studies that show that inpatient treatment is very effective at getting people started and then completed on treatment. I would say mostly it's logistical issues. So it's prescribing inpatient versus outpatient. It's making sure that people can get their full treatment course. Right now, we can only prescribe 1 month at a time. So if somebody starts, if one prescriber prescribes 1 month, they're going to need to have a way to follow up with people to get them their medication for the second month or the third month. So it's still a work in progress, I would say.
Totally. And lots of factors there, of course. My last question is, you said a lot of really promising things about moving forward with like these national goals about curing Hep C and all of that. Have you seen any sea change in any direction, one way or the other, related to the current administration, or is it kind of too soon to tell?
Honestly, I think it's too soon to tell. The big thing was the bill that was announced in June. I don't have any updates about that. I think the HHS funding was also promising. It is a bipartisan bill. I think this is a bipartisan issue, but who knows?
It's anyone's guess. I can take some questions from folks in the room if you have any. Great. Let me bring the microphone to you. Just introduce yourself.
Hey there, I'm Naveen. I'm an intern. Really great talk. I recently came across a patient who was resistant to both of like the first line oral DAAs that you had mentioned. She contracted hepatitis C in the 1980s when she got a transfusion. And so I was just curious if like the chronicity of her disease would have predicted the resistance, and what other factors influence that, as well as how you approach patients who are resistant to those first line agents.
Yeah, that's a great question. So there are some groups that are still a bit more difficult to treat, and so the SVRs are a little bit lower. The more advanced the cirrhosis, the SVRs are still very high, but it's lower, not the 99%. So people with cirrhosis, more advanced cirrhosis specifically, and people with HCC also. And then I'm not sure when that patient had been treated before, but the retreatment therapy that we would typically recommend if they were just treated with one of the first lines would be, the trade name is Vosevi. It's the sofosbuvir, velpatasvir, voxilamprevir. So it's 3 drugs. It has a PI in there. And we have also successfully treated people who have had multiple treatment failures with the Mavorite, the glecaprevir, pibrentasvir, plus the sofosbuvir, plus ribavirin in combination. So that's sort of we can pull that out if we really need to. But we had a case series here at UCSF and Kaiser, Northern California, where we treated about 20 people and all achieved cure with that regimen.
Hi, my name is Mosi, social worker. Thanks for your talk. My question was about your title, Are We There Yet? And do you think because it's not talked about as much in the lethality and with other diseases and things kind of taking prevalence in discussions in society that more people aren't adopting the treatment since it's much more simple than it used to be, like with interferon?
Yeah, I think it's a great question. I think there's a lot of reasons, in part because there's a lot of competing priorities, as you allude to. So it's not front and center necessarily, except for, for me, I'm a hepatologist, and I treat hepatitis C, so I'm a hammer and everything's a nail. But for, there's a lot of other issues that people are facing. So I think that is part of it. And that's part of why I think the integrated care models where people are getting other resources and managing other conditions are really ideal for treatment. And the simplified treatment would be perfect, but those settings really need support. So they need, Hep C champions, and they really need, financial support to actually do that kind of work, because it is a lot of work.
What other questions in the audience?
Only from Transplant ID. Great talk, thank you. Question about the screening. Can you differentiate like acute versus a chronic Hep C when you do the screening? Because I assume that some of the acute Hep C patient will be self-resolving the infections.
Yeah, excellent question. If you're just doing a viral load, you won't, unless, maybe a history if somebody reports a acute exposure. The guidance panel actually changed the guidance a few years back to recommend treatment in people with acute Hep C rather than waiting. In the interferon era, we used to wait because there could be people could spontaneously clear, and the treatment was much more onerous. But now with the DAAs, very effective in acute hepatitis C, and so we don't wait anymore, and we really can't differentiate. That is another advantage of the point of care RNA for screening rather than the antibody first, because the antibody might be falsely negative in an acute infection.
Hi, thanks for the talk. I'm Kaveh. I'm one of the residents. I was struck by the increasing incidence that you showed us data on, and I'm curious what the reasons for that are thought to be. Could increased intensity of testing be one possible contributor to the increase?
Yeah, that's a great question. I'm not sure how the CDC does their modeling. They have it's a reportable infection, so they see what's been reported in terms of acute infections, and then they estimate the number of actual acute infections. And it's a really good question about whether the uptake in screening might kind of just, we're finding it more, and I don't actually know the answer to that. It does parallel injection drug use, and when they're able to identify risk factor, it's usually related to drug use, at least in the United States.
Great. Any other questions in the room here? There was one online about if you happen to know the relative cost in the US versus other countries in terms of diagnostics and treatment, like the DAAs for Hep C.
Oh, that's a great question. I don't know them off the top of my head, but in a lot of other countries, the DAAs are much less expensive. And in contrast, there are some countries where the DAAs are less expensive than the diagnostic testing. So the barrier in some areas is actually doing the RNA test and the diagnostic testing, whereas for us, the barrier is more the DAAs.
Great. Thanks so much, everyone. See you next week.